value that, so if you ask me the exact value, then it will be 7.5, but usually it ranges in between 6 to 8 gram per deciliter. Okay, let me fix it. Okay. Then comes the okay. Then comes the shape of RBC. So what would be the shape of RBC? That we all know the shape of RBC. The God has given us one of the very beautiful cells, that is RBC. Why? Because RBCs are having a specific shape that is called as biconcave shape. So why only biconcave shape is given? Why not biconvex or any other shape has been given to us? Why? Because this shape, this biconcave shape, is the most flexible shape, because due to this shape, an RBC can traverse through smallest blood vessel without any hindrance. Okay, so it's very very important that our RBCs should not entrap within any smallest blood vessel. Like there are capillaries, okay, there are arterioles, and they are having very small diameter. Okay, but the size of RBC is 7.5, so it, you might be get confused that how it will traverse through those small blood vessels. Why? Because it can enter any smallest blood vessel, because it's a highly foldable, highly moldable shape. So that's why this shape is given to the RBC, the biconcavity. And what is the use of this biconcavity? It becomes so much flexible, so it can enter very easily the smallest blood vessel even without any hindrance, any obstruction. Okay. Then comes the lifespan. The lifespan of RBC is around 180 days. 180 days. Sorry, it's not 180, 120. Pardon me, 120 days. Okay, so 120 days will be the lifespan of any RBC. So RBC will be there in our blood till 120 days, and after 120 days it will get destroyed within the spleen itself. Okay, then comes the RBC count. What would be the normal RBC count? Normal RBC count will ranging in between 4.5 to 5.5 million per cubic mm. Okay, and it will be more in males as compared to females. That you all know that in the males there will be more RBC count as compared to the females. Okay, and that's why if you talk about the hemoglobin, if you talk about the hemoglobin concentration, that is one of the most important thing you must be knowing. Hemoglobin concentration, that will be in males, it will be ranging in between 14 to 16 milligram per deciliter, while in females, it will be ranging in between 13 to 15 milligram per deciliter. Okay, so hemoglobin is very, very important for your questions purpose. Why? Because most of the time you will be given hemoglobin concentration in your questions. Okay, so you must be knowing that what is normal and what is abnormal about the hemoglobin concentration. So hemoglobin will be more in males as compared to females. Okay, so in males there will be 14 to 16 not milligram, sorry, it is gram. Okay, remember it is in grams, it will be in grams per deciliter. Okay, so hemoglobin will be 14 to 16 gram per deciliter in males, and it will be 13 to 15 gram per deciliter in females. So this is very simple. You all know. I think everybody knows that what is normal hemoglobin. But the important thing here for question purpose is that what should be the criteria for anemia. Okay, as far as hemoglobin concentration is concerned. So let's talk about the most important thing, that is the anemia. Anemia. So what is anemia? Anemia is when there will be a reduction in hemoglobin concentration or RBC count. So if there is a reduction in hemoglobin concentration or RBC count, it will be called as anemia. Okay. So remember, there are two important diseases related to the RBC. One is anemia and second one is the polycythemia. So when the count is reduced, that is called as anemia. Or second thing is polycythemia, that is just reverse of this condition. Polycythemia, when hemoglobin concentration will increases above the normal limits and RBC count is also increases above the normal limit, that is called as polycythemia. So it is very simple. What we are going to discuss in RBC disorders, basically there are only two diseases. One is anemia, another one is the polycythemia. So whenever hemoglobin concentration or RBC concentration is reduced, that is called as anemia, and whenever RBC count or hemoglobin concentration increases, that is called as the polycythemia. So what should be the exact values of the hemoglobin, or what should be the cutoff of the hemoglobin values when you will consider it as anemia or polycythemia? That is important. Okay, and that is important for your question purpose. So let's see. So if hemoglobin levels are less than 12 gram per deciliter, then it will be called as anemia. Hemoglobin values are less than 12 gram per deciliter, it is called as anemia. And if hemoglobin values are more than 16.5 gram per deciliter, then it will be called as polycythemia. Okay, so this is important. What is anemia? Anemia when hemoglobin is less than 12 gram per deciliter, and polycythemia when hemoglobin is more than 16.5 gram per deciliter. Then it will be called as polycythemia. Okay, so first of all, we'll take the topic that is anemia, and it will be followed by the polycythemia. So as far as the questions purpose, if you ask me that what is the weightage of these topics, then I will say that anemia will be there around 99% times in your exams, and 1% chances are there that the polycythemia related question can be there. So actually, the major burden of RBC disorder is being comprising of the anemia. Okay, but for just for understanding, I talk about those two important things, anemia and polycythemia. Otherwise, for question purpose, the most important topic will be anemia only. Okay, so let's start with anemia. So now you know that what is the definition of the anemia, okay, and what is the criteria for anemia. One more thing about the criteria is when the situation like pregnancy is given to you. So in pregnancy, what should be the hemoglobin concentration to call it as anemia? In pregnancy, hemoglobin should be less than 11 gram per deciliter to call it as anemia. So this is again an important condition you must remember. Otherwise, for male and females, in both of the cases, the criteria for anemia remains the same, and that is that less than 12 gram per deciliter. But whenever they are giving you a special condition like pregnancy, that time the criteria will change. Okay, so that time hemoglobin should be less than 11 gram per deciliter to call it as a anemia. In which condition? In pregnancy. Okay, so I think you got the answer. So hemoglobin concentration less than 12 gram is anemia. If pregnancy is asked, then it should be less than 11 gram per deciliter. And as far as polycythemia is considered, then it should be more than 16.5 gram per deciliter. Okay. So now we'll see the classification of anemia, that how to classify the anemia. Why it's important? Because just saying that the patient is suffering from anemia, this is not sufficient for treatment purpose. For treatment purpose, and if you want to start the treatment, then what should you know? That you should know the exact cause of the anemia. Like there can be a iron deficiency anemia, there can be thalassemia also, there can be hemolytic anemia also. So just saying that the patient is suffering from anemia is not sufficient for treatment purpose. So if we are able to make out that there is iron deficiency anemia, then we'll start the treatment with iron supplement. And if you know that there is a hemolytic anemia, then we'll start treatment accordingly. So that's why it is important to find out that what is the cause of the anemia. Okay, so how you will make out the cause of anemia? If you know the classification, if you know the causes, then only you are able to make out the cause of anemia. So let's see what is the classification of anemia. And what is the basis of this classification? The basis of this classification is the morphology of RBC, or you can say it is also based on RBC indices. So the classification of anemia is based on the morphology of the RBCs, or you can say the RBC indices. Okay. So what RBC indices do we have here? So we are going to talk about the three important RBC indices here. One is MCV, second is MCH, and third is MCHC. Okay, so these are the three important RBC indices, and based on these three RBC indices, we could differentiate anemia into three broad categories. Okay, the first will be microcytic. So microcytic hypochromic anemias. The second category will be normocytic or normocytic normochromic anemias. Okay, and the third category would be macrocytic and normochromic anemia. So it's important to see here that it is not macrocytic hyperchromic. Why? Because if it is hyperchromic, then how it will be anemia? Okay, so that's why the hyperchromia word is not encouraged here. The basic word is normochromia or hypochromia. Okay, so what these words say is microcytic means small size RBCs. Whenever you talk about normocytic, that means there are normal size RBCs. Okay, and what is macrocytic? Macrocytic means when the size of RBC is increased, when there are larger RBCs, that is called as macrocytes or macrocytic. Okay, what is chromia? Chromia means the color of RBC. That we all know the color of RBC is red. Okay, so when color of RBC is less red or the central pallor of the RBC is increased, that is called as hypochromia. Okay, so how a normal RBC looks like, that we must know how a normal RBC looks like. Like I'll tell you, like this. It will be a spherical RBC because we are going to see the RBCs in the 2D, okay, in two dimensions only. So that's why you are not able to make out the exact shape of the cell, that is the biconcavity. So biconcavity can be seen or appreciated only in the 3D picture, okay, not in the 2D. So here we are going to see the 2D picture only in the microscope. So we are going to see the spherical RBCs, okay, the spherical RBCs. And every RBC, every normal RBC will have a central pallor. You can see in the center there is no staining here. This is called as central pallor, because in the center of every RBC, if you stain it, you are not going to see any red color there. So that is called a central pillar. So is it abnormal? No, it is not abnormal. Every normal RBC will have a central pillar, but how big it should be? So in normal condition, it should be less than 1/3 of RBC. So if any RBC is there, and if the central pallor is occupying less than 1/3 area of the RBC, that should be considered as the normal central pallor. Okay, when it is increased more than 1/3, then it is called as hypochromia. Okay, so more it is increased, that means there is more and more hypochromia. Okay, less it is increased, there will be less central pallor, means the RBC is more and more hemoglobinized. Okay, so let's see, like in microcytic hypochromic anemia, in microcytic hypochromic anemia, what kind of RBCs we are going to see here? Like this. First of all, we are going to see the smaller RBCs as compared to the normal RBCs. and there will be a more central pillar like this. So the central pillar will be more and the size of RBC will be smaller. Size of RBC will be smaller. While in macrocytic, the size will be increased and central pillar will be reduced like this. Okay. So there will be a small size RBC and there will be increased central pillar. The increased central pillar is equals to hypochromia. Here there is normal size RBC and it will be having normal central pillar, and normal central pillar equals to normochromia. Here there will be a increased RBC size and there will be a normal central pillar, that is equals to normochromia. Okay, so that's simple is it is that if the size of RBC is normal, then it will be called as normocytic. RBC size is reduced, it will be microcytic, and RBC size is increased, then it will be macrocytic. And as far as word hypochromia is considered, then you have to see the central pillar, how much it is. If it is normal, then it will be called as normochromia. And if it is increased, if central pillar is increased, that means there is pale RBCs. The RBCs color appear pale because mostly RBCs will be having less central pillar and they are more and more red in color. Okay, while in cases of microcytic, you will see the more and more central pillar means more and more RBC. Most of the RBC will not be having any color, so that's why those RBCs will appear paler as compared to the normal RBC. So that is called as hypochromia, means color of RBC is reduced. And which thing is giving the color to the RBC? That is the hemoglobin itself. So more and more hemoglobin is there, there will be a normochromia, and less amount of hemoglobin is there in a single RBC, then it will be called as hypochromia. Then one more thing which is important here, that what is the use of RBC indices. So I'll tell you here RBC indices also. So MCV, MCH and MCSC. MCV, MCH and MCSC. Normal MCV will be in between 80 to 100. The unit is femtoliter, FL. 80 to 100 femtoliter will be the MCV. MCH will be 28 to 32 picograms. MCH will be 28 to 32 picograms. And the MCH values ranges in between 32 to 36 percentage. That is MCSC. So what does MCV tell us? MCV is mean corpuscular volume. MCV is what? It's a mean corpuscular volume. So it will tell us the average volume of a single RBC. So how much should be the volume a single RBC is occupying, that is called as mean corpuscular volume. In other words, I can say that it will tell us the size of the RBC. So if MCV is more, then size is more. If MCV is reduced, that means the size of RBC is also reduced because it tells us the average volume of a single RBC. Okay, so mean corpuscular volume, if it is increased, sorry, if it is decreased, then it will be microcytes. If it remains normal, that means there are normocytes. If it is increased, that means there are larger size RBC that are called as macrocytes. And what should be the the values of MCV here? If MCV is less than 80, it is considered small size RBC. If MCV ranges in between 80 to 100, that is the normal MCV, then it will be called as normocytic anemia. And if MCV is increased above 100 femtoliter in any anemia, then it will be called as the macrocytic anemia. You got the point? Based on MCV, we can differentiate different type of anemias. Like if microcytic, we have to tell the microcytic thing, then it should be less than 80. If it is normocytic, then it should ranges in between 80 to 100. And if it is more than 100, then it will be called as a macrocytic anemia. And what are the values which are important here as far as MCH and MCSC considered? Remember, MCH and MCSC usually follows the MCV values. Like if MCV is reduced, then MCH and MCSC both will be reduced. If MCV is normal, then MCH and MCSC also remains normal. Okay, if MCV is increased, then MCH values will be increased here. But remember, the most important thing is MCHC never increases above its normal limit. Like the normal limit is 32 to 36. Okay, 32 to 36 is the limit of the MCSC. So it will never exceeds above the 36 in any anemia. There are exceptions, but as far as all the other anemias are considered, you will see always that the MCSC will remain normal or it will decrease, but it will never exceeds its maximum limit. What is the maximum limit of the MCSC in a normal individual? That is 32 to 36 percentage. So it will never exceed above the 36. Okay, so remember here it will remain normal. Why? Because it cannot exceeds above 36. So in macrocytic, it is very important that MCV value will be increased. MCH can also increase, but MCSC will never exceeds above its normal values. So that is important. I will tell you later that in which diseases or in which anemias you will see that MCSC is increased above its normal limit. That is exception. Okay, there are very few anemias where you can see MCSC exceeds above its normal limit. Okay, so remember MCFV, MCH, and MCSC all go hand in hand. If MCV is reduced, then MCH is reduced, MCSC is also reduced. If MCV remains normal, then MCH remains normal, MCSC also remains normal. If MCV is increased, then MCH is increased or it remains normal, but MCSC never exceeds above its normal limit. Now the next question comes in our mind that how we can say that the RBC is normal or RBC is increased in size or RBC size is decreased when we are going to see the peripheral blood smear. So whenever you are going to see the peripheral blood smear under the microscope and you are visualizing many RBCs are there, then how you make out whether those RBCs are small in size, normal in size or big in size. Okay, that in that case, what you are going to see, you have to focus on one very important cell in that peripheral blood smear, and that is called as lymphocyte, and that is also small lymphocyte. Always see the small lymphocyte. If you can appreciate the small lymphocyte, then you have to compare the size of the RBCs with that small lymphocyte. Okay, so if small lymphocyte size is similar to the RBC size, that means those RBCs are normal in size, because the normal size of small lymphocyte is also similar to a normal RBC. Okay, so that's why you have to compare the size of RBC with the small lymphocyte to say whether it is larger in size, smaller in size, or bigger in size. You cannot compare the RBC with the other RBC. Why? Because when you will see in the microscope, in peripheral blood smear, you will see many different shape and size of RBCs. Even in a normal individual, you will see that some RBCs are larger, some RBCs are normal, some RBCs appear smaller. Then that time you will get confused whether these RBCs are normal, larger, or smaller in size. So don't compare the size of RBC with other RBCs. You have to compare the size of RBC with the smaller lymphocytes, because the smaller lymphocyte usually have the size just like a normal RBC. Okay, so you have to have a standard cell. Okay, and that standard cell to be compared is lymphocyte. And which lymphocyte? Small lymphocytes. Please remember, not the larger lymphocyte, because in viral diseases like dengue or in corona or in some other viral conditions, you will see the activated lymphocytes in our blood also. Activated lymphocyte or virocyte, those are activated lymphocyte in viral condition, and those are bigger in size. So don't compare the large lymphocytes with the RBC. You have to see the smaller lymphocytes. Okay, how you will make out that the lymphocyte is there? Lymphocyte usually have only and only the nucleus. Okay, there is a cytoplasm, but the cytoplasm is very, very less in the small lymphocyte. So basically, you are going to see the blue color nucleus only. So here also you can appreciate that I have made a diagram where you can see only and only a blue color round or spherical cell, because there is a very less cytoplasm. So cytoplasm will be like this. It will be very scanty that you cannot appreciate in the smear. So you are going to see only and only the blue colored nucleus of the lymphocyte. Okay. So you have to compare the size of RBC with the small lymphocyte. Okay. So Nia, you can see here, if the small lymphocyte, the RBC, if it is lesser than small lymphocyte, then it will be called as microcytes. If RBCs and lymphocytes are equal, then it is called as normocytes. And here you can see that this RBC, the macrocytes are bigger as compared to the small lymphocytes, so that's why they are called as macrocytes. Now you got the point that how you will tell that whether the size of RBC is small, normal, or large. Because in exams they will give you the peripheral blood picture. Straightforward, they will give you the picture and they will ask you that what is it, whether it is microcytic anemia, whether it is normocytic anemia, or whether it's a macrocytic anemia. So how you will make out it? You have to focus on the lymphocyte in that picture, and then you have to compare the size of that lymphocyte with the rest of the all the RBCs which you can see around that lymphocyte. Okay, and you will make out the average thing. Like if all the RBCs around that lymphocyte are appearing smaller, that means they are microcyte. If all the RBCs which are surrounded by that lymphocyte is appearing larger in size, that means they are macrocyte. And on an average, if you see that all the RBCs are looking just similar to the lymphocyte, then you can say that they are the normocyte. I think now you got the point that how you will ascertain whether they are normo, micro, or macro. So there are two things. One is the size of RBC you can make out by peripheral blood smear also. So this thing you can make out on peripheral blood smear. Peripheral blood smear examination. When you will appreciate the size of RBC by comparing it with the lymphocyte. And second thing, you can also make out the diagnosis by looking these three important RBC indices. But how you will calculate these RBCs indices? You need not to calculate anything, because the machine, the automated hematology analyzer, will calculate these parameters for you. Just you have to give the blood to the machine, and all parameters will be calculated automatically by the machine. So what that machine is, that is called as hematology analyzers. So two important things are required for classification of any anemia. You require one of the MCV, MCH, and MCHC value that you will get by the machine itself. And once you will get that the hemoglobin concentration is reduced in machine and MCV, MCH, MCHC values are also altered, then always it should be followed by the PBF. So remember, the first step should be this one, that is hematology analyzer report, and it should be followed by always and always by the peripheral blood smear examination, because sometimes machine will give you the wrong reading also. Okay, wrong means machine cannot ascertain the exact value. Like if there are smaller RBCs are there, and if they will make a clump like this, you can see here, like smaller RBCs are there and they will make a clump like this, and once they will enter the channel of the machine like this, if they will enter the channel of the machine, then the machine will think that there is a single large RBC. The machine cannot differentiate between the clumps of smaller RBCs and a single large RBC. So that time what will happen? You will see the falsely high MCV. Here what will happen? Here you will see false high MCV, because machine will understand it as a macrocyte. So even if there are smaller RBCs and if they will make a clump and they will enter the machine aperture, then machine aperture will think that there is a larger size RBC is entering, and that time it will calculate the falsely high MCV. Okay, so that time you have to be very much cautious that whenever you will get abnormal MCV, MCH or MCHC values, then it should be followed by making a peripheral blood smear, because on smear you will not get this. Okay, because on smear you will calculate or you will ascertain the size of RBC by comparing it with the lymphocyte, and that will be always and always good. That will always and always be the best way to ascertain the size of RBC. Then you will think, then why we are not always making a peripheral blood smear in every case? Because it's not a simple thing, because it's a time-taking procedure. Machines are a very rapid method to calculate the hemoglobin, MCV, MCH, and MCSC value. Because in hospitals we are getting daily the thousands of patients. In all those patients, we usually prescribe the CBC, that is complete blood count, that is being done by the hematology analyzer itself. So due to that huge burden, we cannot make the peripheral blood smear in every case. So in which cases we are going to make the peripheral blood smear? If there is any abnormality is there in MCV, MCH or MCHC value. And that time we have to make the peripheral blood smear to confirm the findings of CBC analyzer. I think now you got the point. The first step in any anemia should be the CBC report, or you have to give the blood to the hematology analyzer. So what hematology analyzer is giving us? That is giving us the CBC. What is CBC? That is complete blood count report. Complete blood count report. And in that complete blood count report, you will get the values of hemoglobin concentration, you will get the RBC count, you will get WBC count, you will get platelet count, and also with that, those all values, you will get the values of RBC indices also. It's like MCB, MCH, and MCSC. So through CBC report, you can make out whether the patient is having anemia or not by looking the hemoglobin values. And then you can also make out that what type of anemia is there, whether it's microcytic, macrocytic, or normocytic, by looking the values of MCV, MCH, and MCSC. But if you want to confirm that okay, it is MCV is less and it should be microcytic only, then you have to go for a peripheral blood smear examination. Okay, then your question will be answered completely. I think now you got the point that how you are going to differentiate between these different type of anemias. Okay. Now we'll see what are the causes of microcytic, what are the cause of the macrocytic, what are the cause of the non-cytic. So let's see. First of all, the microcytic category. What can be the probable cause of the microcytic category? So in microcytic category, we are having iron deficiency anemia. We are having iron deficiency anemia, that is one of the most common anemia in the world. Then comes anemia of chronic diseases. Then comes sideroblastic anemia. And the last one is thalassemia itself. So there are four types of anemia which will be there when the size of RBC will be smaller. So whenever you are going to see the smaller size RBCs in the peripheral blood smear and there is a hypochromia, then what you can think about? You can think about the four important anemias. One is iron deficiency, second is anemia of chronic disease, third one is sideroblastic, and fourth one is the thalassemia. Okay. Then you have to offer a specific test according to the clinical picture, that what kind of anemia it is there, whether it's iron, whether it's anemia of chronic disease, whether it's sideroblastic or thal itself. So first of all, you will make out that it is anemia by looking hemoglobin concentration. Second thing, you will make out what type of anemia it is there by looking the MCV, MCH, and MCSC value. And when you got that it is microcytic or macrocytic or normocytic, then you have to see the clinical scenario of the patient and you have to make out certain differential diagnosis based on those clinical appearance. And then you have to offer the special test according to the special anemias. Okay. So we'll talk about those special tests and approach to those anemias after completing this classification. Okay. So what comes in the normocytic category? What comes in the normocytic normochromic anemias? So in the normocytic normochromic anemias, we will have the blood loss, First of all, the anemia due to blood loss will be there in the this category, that is the normocytic normo. But it should be acute. Remember, it should be acute blood loss. Why I'm telling you this acute? Because in chronic blood loss, when we are losing RBC day after day, slowly, we are also losing the hemoglobin within those RBCs, and also we are losing the iron that is there in that hemoglobin. So slowly, what will happen if the blood loss is there for a so longer duration? Slowly, we are going to lose the iron also, and slowly, patient will become iron deficient. So that's why whenever there is a chronic blood loss, that time patient will have the iron deficiency anemia. But whenever there is acute blood loss, that time if you see the peripheral blood smear of that patient, it will be having only normocytic normochromic anemia. Okay, so you must be getting confused that if the size of RBC is normal and if the chromia is also normal, then how it can be anemia? Lots of students used to ask me that if sir there is a normal RBCs in the peripheral blood smear and if there is normal chromia, the color of RBC is also normal, then how it can be abnormal? Okay, yes, there is confusion, but it's very simple. Understand? Like if in a normal individual, if there are 5 million RBCs are there, okay, and due to any reason, if those 5 million RBCs are reduced to 2 million, then what will happen? Is it anemia or not? Yes, it will be anemia because RBC count is reduced. But in those remaining 2 million RBCs, if you make a peripheral blood smear, then how it appears? Those 2 million RBCs are appearing just like a normal RBCs. So how it can be anemia? Because the total number of RBC is reduced. The remaining RBCs which are there in our blood, and we are making the peripheral blood smear through those RBCs will appear completely normal, like a normal RBC. So this is due to the total burden of RBC in our blood is reduced. That's why that anemia is there. So how our total burden of RBC can be reduced in our blood? That is important. First of all, from where we are going to get the RBCs in our peripheral blood? The factory of all the RBCs, or I can say all the blood cells, will be the bone marrow itself. So whenever our bone marrow is suppressed due to any reason, we are not able to make the normal number of RBCs on daily basis. And slowly, in the peripheral blood smear, in the peripheral blood, you will see that the RBC number will be reduced slowly. Why? Because the number or the lifespan of RBC is exact. Like after 120 days, every normal RBC that is there in the blood is going to die. Okay, so if RBCs are not produced by the marrow in a appropriate pace, then slowly the RBCs which are there in the peripheral blood, after finishing their normal life, they will get reduced in the blood. Okay, so normally what will happen? Normally, whenever RBCs are destroyed or dying in the peripheral blood, with the same speed, our marrow is throwing new RBCs into the blood. So that's why we are having normal RBCs. But what will happen if bone marrow itself is suppressed? Then what will happen? The bone marrow is suppressed. Now there are no newer RBCs are coming into the peripheral blood, and after a few days, you will see that the RBCs which are already there in the blood, they are going to die after their normal life, and slowly, patient will develop the anemia. And if you see the remaining RBCs which are there in that blood, and if you make a peripheral blood smear of that smear, the RBCs which are there in now in the blood, they will appear normal in size, normal in shape, normal in chromia. Getting my point? Because the bone marrow is suppressed. Bone marrow is not pouring new RBCs into the blood. So that can be the second cause, when there will be normal size RBCs in the blood, but still the patient is having the anemia, because the total burden of the RBCs are reduced in our blood. So the second cause can be bone marrow suppression. Bone marrow suppression, and it is also called as aplastic anemia. So what is bone marrow suppression? That is aplastic anemia. Okay, got the point? Aplastic anemia or bone marrow suppression. Third thing, the bone marrow is making or having a normal activity. Bone marrow is throwing new RBCs into the peripheral blood every time. Everything is normal, but the newer RBCs are getting destroyed within the blood itself. The newer RBCs are getting destroyed within the blood itself. And if you make the peripheral blood smear of that patient, the RBCs which are still intact, the RBCs which are still intact that are not destroyed, you are going to see those cells only. Na? So those cells will appear like a normal RBCs. Okay, so whenever there is a peripheral blood RBC destruction in any condition, that time also you are going to see the remaining normal RBCs. So that is condition called as hemolytic anemia or hemolysis. So whenever RBC destruction is taking place in the peripheral blood, that time also the remaining RBCs appear like a normal RBC. So that can be the third cause. So what can be the cause of the normal size RBCs in anemia? When bone marrow is not able to make normal RBCs. First of all, that is the bone marrow suppression or aplastic anemia. Second thing, bone marrow is making newer RBCs every time with the normal speed, but when these RBCs reaches to the peripheral blood, there is some reason and the cells are destroyed. That is called as hemolytic anemia. That can be the second cause where normocytes will be seen. The third cause, the bone marrow is normal. There is no peripheral blood destruction of any RBCs, but RBCs are getting lost from our body due to some reason, like there can be a road traffic accident. Due to road traffic accident, patient used to lose lot and huge amount of the blood volume. So the RBC total number of RBC will be reduced in the blood, and that will be having the anemia due to the blood loss. So you got the point. The three important cause will be the hemolysis, the bone marrow suppression, and the blood loss. In some cases of anemia of chronic disease, you can see the normocytic picture. Not always, but in some cases you can see anemia of chronic disease. You can see the normal size RBCs. Anemia of chronic disease. Okay, that thing you have to remember, that anemia of chronic disease will be there in the both of the categories. Anemia of chronic disease can be there in normal size RBCs also, and it can have the microcytes also. So now I think you must be assured that why there is anemia if RBCs are looking just like a normal RBC. Next thing, the macrocyte, the larger RBC. So larger RBCs will be seen in which condition? Larger RBCs will be seen in the macrocytes, or macrocytic anemia will be seen in megaloblastic anemia. So the one and only cause is megaloblastic anemia. So it's very important, it's very simple, and it was asked in your 2018 exam. They asked very simple question. That was the simplest question, that if MCV is 110, then what should be the anemia? And the answer was megaloblastic anemia. Okay, so it was very simple because the MCV values were given that time, and that was 110 MCV femtoliter. That is more than 100, so it must be a megaloblastic anemia. So megaloblastic anemia. Next question, which is very frequently asked in your exam, that what are the causes of non-megaloblastic macrocytes? Non-megaloblastic macrocytes in a blood. Non-megaloblastic cause of macrocytes. So what can be the non-megaloblastic cause of the macrocyte? Like there can be a hypothyroidism. So in hypothyroid patient, you can see that the RBCs are larger in size. So macrocytes can also be appreciated in hypothyroidism. That you have to see. Okay. Alcoholism is another cause. Then comes liver diseases, chronic liver diseases, not acute, chronic liver diseases. So hypothyroidism, alcoholism, chronic liver diseases, some cases of aplastic anemia, not all. Most of the cases will be there in the normocytic category, but some cases of aplastic anemia can also be there in macrocytic. So hypothyroidism, alcoholism, liver disease, they are the most important, but some cases of aplastic can also be there in the macrocytic category. But basically, in most of the cases of most of the cases of aplastic anemia, that will be there in the normocytic category. Even in newborn, physiological. If they ask that what is the physiological macrocytes are seen in which condition? Physiological macrocyte means patient is not having anemia, patient is not having any disease, but still patient is having the macrocyte, that is there in newborn. So remember, newborn used to have the larger size RBCs as compared to the adult, and that is the physiological. That is not abnormal. So this is important. So physiological macrocytes are seen in which condition? Physiological macrocytes are seen in newborn. So newborn used to have the larger size RBCs, and that is not abnormal. That is a completely a physiological condition. So I think these are the all the different types of anemia in the different categories. Now we'll see one by one these categories, their approach, and finally we'll make out the diagnosis. Okay. So we'll start with the first category, that is the microcytic hypochromic anemia. Microcytic hypochromic anemia. Okay, so how you are going to make out the diagnosis? It's very simple. Just see the hemoglobin. Hemoglobin will be less than 12 gram. That is the anemia. That is the and definition of anemia. Then you are going to see the MCV, MCH, and MCHC value. If MCV is low, MCH is low, MCHC is low. That will tell us that this is a microcytic hypochromic picture. Microcytic hypochromic RBCs are there in that anemia. Microcytic and hypochromic RBCs are there in the blood. Okay. Now you will get confused at what type of anemia it is, whether it's iron deficiency, whether it's a sideroblastic, whether it's a anemia of chronic disease, or whether it's a thalassemia. Okay. So how you will make out that which type of anemia it is? So we'll see one by one. First of all I'll tell you the iron deficiency, and then it will be followed by the rest of the anemia. Then finally I will tell you that how you will approach to a case of microcytic hypochromic anemia. Okay. So first of all, I'll tell you the IDA, iron deficient anemia. Iron deficiency anemia. So remember, this is the most common nutritional anemia in world. This is the most common nutritional anemia in world because it is related to the nutrition also. So this is the most common nutritional anemia of world, especially common in developing countries. Okay. Second thing, what can be the cause of this anemia? How patient will get iron deficient state? So patient will get iron deficient state by different ways. Like one of the cause can be one of the important cause can be the dietary deficiency. That is the most common cause in the world as far as iron deficiency is related. Dietary deficiency. So where it is common in? It is common in developing countries. The question is there specifically asked that which is the most common cause of iron deficiency anemia in developing countries, then answer will be the dietary deficiency of the iron. Second thing, what can be the cause in the developed countries? Then that will be the chronic blood loss. So the chronic blood loss will lead to iron deficient state. So what can be the cause of chronic blood loss? Chronic blood loss can be due to the menstrual irregularity, to menstrual related problems, like sometimes female used to have the menorrhagia, long duration of the menses. That time the female used to lose huge amount of the blood for a longer duration. That time patient will have the iron deficient state. So menstrual problem is one of the cause. Then there can be hemorrhoids. Hemorrhoids that are called as piles also. The piles is one of the very common condition where you will see the chronic blood loss. And if there is an old age individual and you are not able to make out that what can be the cause of that much severe anemia in old age, then always think about the GI cancer. GI cancers in old age. So GI cancer in old age is one of the very important cause of the blood loss in stool. Okay, and even it will be a very small in amount, so that's why you are not able to see the frank blood in the stool. So that time you have to see the occult blood. Okay, that is called as occult stool blood test. Okay, so always whenever there is a unexplained iron deficiency anemia in old age, always evaluate that patient for GI cancer. It might be a case that you are going to catch hold those cases even by just a very simple thing, and that is a severe iron deficiency anemia in old age that is unexplained by any other cause. Then always evaluate for occult stool blood test, and if occult stool blood test come positive, then always go for the colonoscopy examination or GI endoscopy to visualize the GI cancer. And you will see that it's a very important thing that you are going to make a great diagnosis just by a very simple thing, and that is the iron deficiency. Okay, so that's why it is important. Remember, GI cancer in old age is one of the very important cause of the chronic blood loss. Otherwise, hemorrhoids, menstrual problems, so many other causes can be there. Next thing, patient is eating sufficient amount of the iron in the diet. Okay, there is no chronic blood loss, but still patient is having the iron deficiency. Then what can be the cause? The cause will be the the iron which you are eating in your diet is not getting absorbed from the GIT, and that is called as malabsorption of iron. So malabsorption disease will be the next option for the cause. Malabsorption disease. So what can be the disease in malabsorption conditions? What other diseases will be there? The most important disease is celiac screw, Whipple's disease. Okay, so how you will remember the diagnosis, whether it's celiac or Whipple's or any other malabsorption disease, by remembering the site of absorption. Okay, so what is the site of absorption of iron in GIT? Remember, in GIT, absorption is taking place from the duodenum. Duodenum is site of iron absorption. So anything, any disease which affects the duodenum, that is going to affect the iron absorption also. So that's why celiac disease and Whipple's, these both diseases usually affects the duodenum of the GIT. So that's why they will lead to iron deficient state, because there will be a malabsorption of iron is taking place whenever there is celiac and Whipple's are there. So duodenum is the site of iron absorption. So that is again an important question. Okay, this is again important question because this is already there in your exam in 2014 exam, that which type of anemia will be seen in celiac screw, and answer was the iron deficiency, because celiac screw affects the duodenal area. You got my point? So that's how they will ask the question. Like they can ask the question that in uh, cases of colon cancer, what type of anemia will be seen? That will be a iron deficient, because colon cancer is specifically used to have the GI bleeding, because that cancer used to bleed lot. Okay, so there can be dietary deficiency, there can be chronic blood loss, there can be a malabsorption. These are the important causes. One more important thing you must remember: there is a parasite which used to affect the duodenal area. Okay, that parasite can also lead to iron deficiency, and that parasite is called as hookworm infestation. Hookworm. Okay, that is also called as ankylostoma. Ankylostoma duodenale. Duodenale. So if you remember the name of the hookworm also, you can remember the site of absorption, that is ankylostoma duodenale, because it affects the duodenum, and duodenum is the site of iron absorption. So that's why it also affects the iron absorption. So the children who are suffering from the hookworm infestation, they usually suffer from the iron deficiency anemia. So these are the few important causes that you must know whenever you're thinking about the iron deficiency, because it's not only a simple thing that the patient is having iron deficiency anemia and you just started the treatment. because if you are not able to make out the cause of iron deficiency, then patient will again have the same disease within few days, even if you are supplementing the iron. Why? Because you are not rule out the cause. Like if there is a blood loss, then you have to treat the blood loss also. If there is a celiac sprue, then you have to treat the celiac sprue also. Otherwise, the patient will have always and always again the same disease. Okay, so it's very very important to understand the pathogenesis of any disease so that you can cure the disease, just not the treat the disease. You have to cure the disease so that patient will not have the disease again and again. So that's why the cause of every disease is important. Now, next thing will be the what will be the sign and symptoms in this condition. Sign and symptoms in iron deficiency anemia. Like pallor will be the sign of anemia that will be there in any kind of anemia. So that is not important. The presence of pallor will be there in the every type of anemia. So I'll talk about the specific sign and symptoms that are related to the iron deficiency anemia so that you will get the answers of important questions. Okay. So what are important things about iron deficiency anemia as far as sign and symptoms are considered? Like there will be a glossitis, that is again important thing that is seen in the iron deficiency anemia cases. Glossitis, that is the inflammation of the tongue. So tongue is inflamed here, that is glossitis. Then there can be a post-cricoid esophageal web formation. Esophageal web formation. Esophageal web means there will be a fibrosis in the esophagus. That is again important finding that is seen in the some cases of the iron deficiency anemia that the patient will have in the post-cricoid area, the area which is just behind that cricoid, the area is esophagus. In the esophagus, upper part of the esophagus, you will see the fibrotic band that is called as the web. It will be like a web, but actually what is it? It is a fibrosis. Why it is important? Because it's a pre-malignant condition also. It can lead to squamous cell carcinoma of esophagus after certain years. Squamous cell carcinoma, esophagus. So that thing you have to remember that which pre-malignant condition of esophageal carcinoma can be seen in iron deficiency anemia. So that is important question, that which is a pre-malignant condition that can be seen in iron deficiency anemia then can leads to esophageal carcinoma, and that is the post-cricoid web formation. Okay, so if patient is having glossitis with esophageal web plus IDA, iron deficiency anemia, then this whole thing will be called as the stride is called as Plumner Wilson syndrome. Plumner Wilson syndrome, or it is also called as Peterson Kelly syndrome. Peterson Kelly syndrome. So when patient is having glossitis, with that there is a post-cricoid web formation, and with that, if there is a iron deficiency anemia, all those three things are there in the same patient, then it will be called as Plumner Wilson syndrome or Peterson Kelly syndrome. Plumner Wilson or Peterson Kelly syndrome. Okay. Then comes one more important feature which is there in these patients, and that is called a koilonychia. Koilonychia is spoon-shaped nails. Okay, you see the spoon-shaped nail, that is a depression in the nail. Depression will be there in the nail, so that is called as spooning of the nails. That is koilonychia. That is also there in the iron deficiency anemia. But remember that Plumner-Wilson syndrome, there will be no in Plumner-Wilson syndrome, there will be no koilonychia. So what is not there in the Plumner-Wilson? Koilonychia is not the part of the Plumner-Wilson. Koilonychia is the another thing which can be there in the iron deficiency anemia, but that is not the part of the syndrome. You got my point? So glossitis will be there, esophageal web formation will be there, and iron deficiency it is there. Then it is called as Plumner-Wilson. Okay. But it is very, very important because sometimes they will ask you the question that koilonychia is the finding of which type of anemia. So koilonychia will be seen in these kind of anemia, that is the iron deficiency related. Okay, so this is about the all the important sign that you can make out in these patients. One is very important symptom also that is there, that is called as pica or pica. Pica or pica, what is pica or pica? Pica or pica is eating non-edible, eating non-edible, non-nutritious food, eating non-edible, non-nutritious food, non-nutritious substance, not food, the substance. Like patient will eat the sand, cement, chalk, ice cubes, and so many other things. So these things are not edible first of all, and if they are edible, then they are non-nutritious. Eat lot of these things in the schools, and the parents think that the child is suffering from the calcium deficiency. Why they are thinking calcium? Because they used to eat chalk a lot in the classes. Okay, so but that is not the calcium deficiency, that is a psychological urge that is seen in child. That is seen in the iron deficiency anemia, that is common in children, and it is not due to the calcium deficiency. Actually, it is due to the iron deficiency. So those children should be supplemented by giving a iron supplement, not the calcium. You got my point? So that is very, very important. So remember, pica or pica is also very important, one of the feature of the iron deficiency anemia. So patient comes to you with the low hemoglobin, low MCV, low MCH, and low MCSC. So you got to know that it's a case of microcytic hypochromic anemia. You evaluate the patient for sign and symptom, but you are not able to make out any specific sign and symptom. Then what you are going to do? Because everything which we used to read here, that is not going to be seen in the patient also. Like esophageal web is not a very common thing that you are going to appreciate in every iron deficiency anemia. Koilonychia is also not common. So most of the time when patient comes to you with the mild iron deficiency anemia, the patient will not be having any specific sign and symptoms of the iron deficiency. He or she must be having only and only the pallor which you can appreciate in the tongue or eye or in the nail only. Okay, so that the only thing you are going to get in anemia of iron deficiency. So then how you are going to make out whether it's iron deficiency or sideroblastic or anemia of chronic disease or it is a thalassemia. So that time you have to be focused on the laboratory parameters. So remember, one thing I'm giving you that is very, very important, that every anemia has to confirmed by lab diagnosis. So what is important here? No signs, no symptoms are confirmatory in most of the anemia. So in the most of the anemia, what will be the crucial thing? What will be the definitive thing? And that is the definitive diagnosis will be ascertained only by a laboratory parameter. So always we are focused on the laboratory parameter. So how a lab is going to help us? So let's see. First of all, what test you are going to offer to a case of microcytic anemia? You are going to give the CBC prescribed for that. In CBC, what you are going to get? In CBC, we are going to get hemoglobin will be low, MCV low, MCH is also reduced, MCSC is reduced. That is the anemia and microcytic picture that we got from the CBC examination. And I told you that whenever there is abnormal CBC, you always have to follow it by making a peripheral blood smear. So now we'll make a peripheral blood smear and we'll see it under the microscope that what is there. Peripheral blood smear examination. So on peripheral blood smear examination, what you are going to get? You are going to get the microcytes and you are going to get the hypochromia. So microcytes and hypochromia we are going to get there in the peripheral blood smear examination. In peripheral blood smear examination, we are also going to see the RBCs which are pencil shaped RBCs. That is also a finding of the iron deficiency anemia. You are going to see the these kind of RBCs, like these long, elongated, flattened RBCs that are called as pencil shaped RBCs, or they are also called as leptocytes. Okay, so pencil shaped RBCs are seen in which anemia? In iron deficiency anemia. Microcytes and hypochromia will be seen in every kind of microcytic hypochromic anemia, but pencil shaped cells are specifically seen in iron deficiency anemia. Remember, WBC will remain normal. WBC count will remain normal in these patients. While platelet count is important here. Why I am telling you? Because platelet count will increase. So that is called as increase. That is also called as reactive thrombocytosis in iron deficiency anemia. So please remember this thing: reactive thrombocytosis. So in cases of iron deficiency anemia, the WBC count remains normal, the morphology remains normal, while in platelets, I'm not saying some cases, in most of the cases you will see that the platelet count will be increased bit more. Like normal platelet count will be 1.5 to 3.5 lakhs, but it will be around like 4 lakhs or 4.10 or 3.80 lakhs. Okay, so that kind of bit more increased platelets will be seen in iron deficiency anemia cases, that is called as reactive thrombocytosis. Like so many females student comes to me in my classes that, sir, I have done my CBC examination and I got to know that I am having more platelets as compared to the normal individual. So why I'm having this? Because most of the females are having a mild type of iron deficiency anemia, and that will be there the cause of that increased platelets in females, in young females, like that is having the menstrual problems or menorrhagia or any other thing. Okay, so that is very common in females because of the problems in the menses. So they used to lose the blood every time. That's why they used to get the mild iron deficiency, and that's why if you see their platelet count, it will appear bit more as compared to the normal level. So don't get panic about this reactive thrombocytosis. Once you are going to treat the iron deficiency anemia, it is going to be treated at all. Okay, so it is going to be treated automatically if you treat the iron deficiency. So that is about the peripheral blood smear examination in cases of iron deficiency anemia. So we started with the CBC, that is followed by the peripheral blood smear examination. Is bone marrow is required or not? No, bone marrow examination is not required here. Remember, bone marrow is not required here. So still we are not able to make out the exact diagnosis that it is iron deficiency anemia, because on peripheral blood smear also we are getting only the same thing, that is the microcytic hypochromic picture. So how to confirm it is a iron deficiency? For that you have to go for definitive diagnosis. For definitive diagnosis, we are based on what? For definitive diagnosis, we are dependent on what? We are dependent on the serum iron profile. That is the answer. So we have to go for serum iron profile to see whether the patient is actually having iron deficiency or not. Okay, because by CBC and peripheral blood smear you can make out only one thing, and that is the patient is having microcytic hypochromic anemia. So if you want to label it as a iron deficiency anemia, then you should go for serum iron profile. So what will be there in serum iron profile? Let's see. So in serum iron profile, what we are going to do, we are going to offer certain tests to the patient, like we are going to offer the patient serum iron, serum ferritin, serum transferrin, saturation, okay, serum transferrin saturation. Then comes serum TIBC, TIBC, that is total iron binding capacity. Then comes serum transferrin receptor assay. So these are the important tests that you are going to offer to any case where you are having a suspect that it can be a case of iron deficiency anemia or microcytic picture is there. Okay, so how it will help us? Like serum iron will be decreased or low in cases of iron deficiency anemia that we all know, because this is the iron deficient state. If iron deficiency is there, then the blood will not having the sufficient amount of the iron, so that's why the blood levels of iron will be low or reduced. Serum ferritin, what it tells us? Serum ferritin tells us the bone marrow iron status. It tells us indirectly the bone marrow iron stores, so that how much iron is there in our bone marrow, that will be ascertained by the serum ferritin values. Okay, so serum ferritin value tell us the bone marrow iron status. So here in iron deficiency anemia, as we know that in the blood there is no iron, so bone marrow will also not be having sufficient amount of iron status or iron stores, so that's why serum ferritin levels are also reduced or low. And one more thing, this is the most sensitive IDA parameter. This is the most sensitive IDA parameter, or the first parameter to be reduced in blood in cases of iron deficiency anemia, even before the serum iron. So it is possible that you will get some patient which are having mild iron deficiency anemia, and in that patient, if you go for serum iron, it also comes normal. And even if you go for serum ferritin in that patient, then you will see that the serum ferritin levels are low. So which is the first parameter to be reduced in iron deficiency anemia cases? That will be serum ferritin, not the serum iron. So remember, in very early stages, serum iron can remain normal also. Remember, so it will be low or it remains normal in early stages. So that's why don't depend on serum iron for iron deficiency anemia. So what is the reliable marker for iron deficiency anemia? That will be the serum ferritin. Remember, the first parameter to be reduced in blood in cases of iron deficiency anemia will be the bone marrow iron stores will be reduced, and that is the serum ferritin. Serum transferrin saturation. What does it mean? What is saturation? Who is going to saturate whom? So here remember, the iron is not able to saturate transferrin because iron is not there. Iron is less amount there, so that's why it is not able to saturate the transferrin valencies. So that's why the saturation of transferrin will be low there or fall there. So this is very important. The transferrin saturation will be low in iron deficiency anemias. Why? Because there is no sufficient amount of iron that is there in the blood to saturate all the valencies of the transferrin molecule. Transferrin is what? Transferrin is the iron transporter in the blood. So whenever iron reaches to the blood from the GIT, it is going to bind with the transferrin molecule, and the transferrin is going to get that iron molecule up to the bone marrow. Okay, so the carrier of the iron from the blood to the bone marrow will be the serum transferrin. Okay, total iron binding capacity. What is it? It is the capacity of what thing? It is the capacity of transferrin to bind with iron. So tell me whether it is going to increase or decrease. Whether it is going to increase or decrease. Answer me whether it is going to increase or decrease. The capacity of the transferrin to bind with the iron, whether the transferrin wants to increase its capacity or wants to decrease its capacity in iron deficiency state. Yes, very good. Because it is going to increase. It's a compensatory mechanism. So whenever iron is less in blood, the transferrin molecule wants to bind with the every molecule of iron so that it can bind with the all the iron that is there in the blood, and it will carry it to the bone marrow. So remember, the saturation will be falling because iron is not there to saturate the transferrin. So that's why the saturation of transferrin will be falling, but the capacity of transferrin is going to increase. Why? Because it's a compensatory mechanism by which transferrin wants to bind with every molecule of iron which is there in iron deficient state. So remember, the capacity of transferrin to bind with iron will be increased, but iron is not there. So that's why iron is not able to saturate the transferrin. That's why the saturation is falling while the capacity of the transferrin will be increased. So transferrin will try to bind with every molecule of iron that is there. So that's why it is going to increase its binding capacity. While there is no iron to bind with the transferrin, that's why iron is not able to saturate the transferrin. So that's why serum transferrin saturation will be falling while the capacity of the transferrin to bind with the iron will be increasing. One of the very important marker is serum transferrin receptor assays. This is very popular nowadays. Why? I'm telling you, serum transferrin receptor assays will be increased. What does it mean increase? Where do we have these receptors? So transferrin receptors are present on erythroid cells in marrow. On erythroid cells in marrow. So what does this receptor wants? So this receptor is present on the surface of erythroid cell. Like this is the erythroid cell. On its surface, we are having this transferrin receptor. What is the function of this transferrin receptor? This transferrin receptor used to carry the transferrin plus iron from the blood. Okay, so every iron and transferrin molecule complex, when it will enter the bone marrow, it will enter the erythroid cells only by this receptor. So what should be there? What should be the status of this receptor? Whether it should increase or decrease in iron deficiency? It should be increased. It is again a compensatory mechanism. So more and more iron deficiencies there, the erythroid cells wants more and more iron to be absorbed from their surface. So they will increase their serum receptor assay, and more receptors will be there on the surface of the cells. More and more receptors are going to leak into the blood also, and then you are able to make out the levels of those receptors in the blood. So more and more crowding of the receptors will be there on the cells of the erythroid. More and more receptors are going to shed into the blood also, and you are going to ascertain, or you are going to measure those levels in the blood. So remember, whenever there is iron deficiency, the erythroid cells wants more and more iron to be there, and it is increasing their capacity by increasing the receptor number on the receptor number at the surface of the cells. And more receptors are there on the surface of the cells. More and more receptors are going to leak into the peripheral blood, or more and more receptors are going to shed into the peripheral blood, that you are going to measure. So remember why it is important when we are having the serum ferritin levels, when we are having TIBC and all the things, then why it is important to measure this thing. Because remember, if you have to differentiate IDA from anemia of chronic disease, this is a very good parameter. So to differentiate IDA from anemia, what will be the test you are going to offer to the patient? And that is the answer. To differentiate IDA from the anemia of chronic disease, we are going to offer serum transferrin receptor assay. Because in IDA, this will be increased, while in cases of anemia of chronic disease, it will remain normal. So remember, serum transferrin receptors will increase only in iron deficiency states, not in anemia of chronic disease. So this is one of the very good tests to differentiate IDA from the anemia of chronic disease. Okay. One more test which is given in your books that is far more sensitive than any other thing. So if you ask me the order of the best test to differentiate between the IDA from anemia of chronic disease, then I will tell you the first thing will be the ratio of what? The ratio of serum transferrin receptor assay, transferrin receptor divided by log ferritin. This is the one of the most important tests. After it comes the transferrin receptor status, transferrin receptor assay. If it is not given in your option, then you can take the serum transferrin receptor assay. If it is not given, then you can go for ferritin values, serum ferritin. So first of all, the most important test will be the transferrin receptor to log ferritin, which is very similar to the transferrin receptor. So here also it will be increased in IDA. It will be increased in IDA while it will remain normal in ACD. Here also remember the same thing. It will increase in IDA and it will remain normal in ACD. While as far as ferritin is concerned, ferritin will be low in IDA while it will be high in ACD. And why it is high in ACD, I will tell you later. In ACD, in anemia of chronic disease, how it is increased in anemia of chronic disease. So that's why it is very, very important. Please remember that how to differentiate anemia of chronic disease from the IDA. The first and best marker will be the transferrin receptor to the log ferritin ratio. Then comes the transferrin receptor status. Then comes the serum ferritin values. So please write it down. This is one of the very, very important questions which is very frequently asked in your exams. From last 5 years, if you will see, then you will see that around 2 to 3 times these kind of questions are there in your exams. That which is the most sensitive test for the IDA, which is most sensitive test to differentiate IDA from the anemia of chronic disease. Then different exams they will be giving you different options. I think you must have write down this thing. Okay, so let's proceed to the next thing. So this is about the diagnosis of the iron deficiency anemia. Okay, so if any of these parameters are there, you can simply diagnose the iron deficiency anemia. Next comes the, the treatment of the treatment of IDA. The treatment of IDA will be iron supplement. Iron supplementation. So we have to give the 200 milligram elemental iron in form of oral ferrous sulfate or ferrous gluconate tablets. Gluconate tablets. Okay, so 200 milligram elemental iron will be given in oral tablet forms, that is ferrous sulfate or ferrous gluconate. Lots of different iron preparations are there available in the market, but one of the very good tablets are these two ferrous sulfate or ferrous gluconate tablets. What is the best route for giving the iron supplement? That is the oral route. Always oral route will be the best. Okay, so whether we can give the injectables also? Yes, injectable forms are also available. Injectable forms are available in form of iron dextran injection or iron sorbitol. But when to give these iron injections? When patient is having a malabsorption condition. Because if you will give the oral drugs, that time they are not be able to be absorbed by the GIT because of malabsorption disease, or if there is a severe anemia. If there is a severe anemia, then that time you have to give the injectables. Okay, so to increase the serum iron levels rapidly. So whenever severe anemia is there, whenever malabsorption is there, that time iron dextran or iron sorbitol injections has to be given. Then comes the what is the best way to assess treatment response. Like patient comes to you and he or she might ask you that how I will feel that my treatment is responding. So it is not the signs, symptoms, or any other parameters. Remember, it's very simple to assess the treatment response by assessing the reticulocyte count. What is the answer? The reticulocyte count. Answer is reticulocyte count. So remember, in IDA, in IDA, reticulocyte count remains low. In IDA, reticulocyte count usually remains low. Okay, and as treatment is started, as treatment is started within 4 to 7 days, reticulocyte reach to peak value. Reticulocytes count reaches to peak reaches to peak value. So that's how you can make out that okay, the patient is having the response with the iron supplementation. So remember, in normal condition, in iron deficiency states, when patient is not being treated, that time if you see the what is the normal reticulocyte count? Normal reticulocyte count usually range between 0.5 to 2.5 percentage. Okay, and in IDA cases, it will be less than 0.5. Okay, and as you will start the treatment, it will reaches about the 2.5 within 4 to 7 days, and that's how you can make out that okay, patient is responding to the iron supplementation. So that is very important. Okay, nowadays one more parameter is there in the market that is becoming more popular nowadays, that is called as reticulocyte hemoglobin concentration. Reticulocyte HB concentration is nowadays becoming more popular. Okay, so if in option only reticulocyte count is given, then that will be your answer. If reticulocyte hemoglobin concentration is given, then it become more sensitive as compared to the reticulocyte count itself. What is reticulocyte hemoglobin concentration? That means we are measuring the hemoglobin that is there within the reticulocyte, not in all the RBCs, that is within the reticulocyte. So that's how you can at very early stage you can see whether the patient is having treatment response or not. So don't depend on the hemoglobin concentration or sign or symptoms or RBC count for assessing the treatment response. You have to depend on the two important things. If reticulocyte count is given, that is the best answer. If it is not given and reticulocyte hemoglobin concentration is given, that is the again a good choice. So next thing which comes in your mind, that what is this reticulocyte? What are reticulocytes? Reticulocytes are the immature RBCs or erythroid cells. Immature RBCs or they are erythroid cells. So how you will differentiate it from the RBC? In peripheral blood film, if you see that there are these kind of RBCs that are not reddish, but they are the slightly blue in color. So these bluish large size RBCs in peripheral blood, they are called as polychromatophilic cells. Polychromatophilic cells. Okay, they are the reticulocytes. But on peripheral blood smear, you can call these cells as polychromatophilic RBCs. You cannot call them reticulocytes. So how you will call them reticulocytes? So you have to apply a special stain on the peripheral blood smear to see the exact count and morphology of the reticulocyte. So what is that stain called as? That stain which you are going to apply on peripheral blood smear to see the exact number of the reticulocyte, that is called as the that is called as supravital dyes. Supravital dyes. What supravital dyes do we have here? We are having two important supravital dyes. We can apply new methylene blue. We can apply new methylene blue on the smear, or we can apply the brilliant crescile blue. Brilliant crescile blue. So these are the two important supravital dyes which you can apply on the peripheral blood smear to see the reticulocytes. So now how reticulocytes will be appearing on this stain? Like, let me show you the actual photograph. Okay. Okay. So you can make out that there are the RBCs in this picture which are having no nucleus, and there are certain RBCs are there in this picture which can show us the bluish color dots or filaments. All the cells, all the RBCs which are having bluish color dots or bluish color filament in this picture, they are the reticulocyte. And what is the stain here? The stain here is the new methylene blue. Okay, so how you will make out whether the normal stain is given to you or whether the spatial stain is given to you? Whenever the whole picture is appearing blue in color, you can see the whole picture is appearing blue in color. RBCs are not appearing red in color. The RBCs are also appearing slightly blue in color. That means this is a spatial stain, that is a new methylene blue. And in certain RBCs you can see there is a, in the certain RBCs you can make out that there are bluish filaments or bluish thread. What are they? They are the remnants of RNA. What are they? They are the remnants of RNA which are there in the reticulocytes. So how you will make out whether they are the RBC or reticulocytes? Very simple. Whenever RBCs are having these color of bluish dots or filaments, those are called as the reticulocytes. So you have to focus the area in the microscope where you can appreciate almost 100 RBCs. Okay, and out of those 100 RBCs, you have to calculate that how many RBCs are containing these bluish thread or filaments. Okay, like if there are 100 RBCs and out of those 100 RBCs, like in this area I can calculate, like if it's in this area, if these are the 100 RBCs, and if there are 1 2 3 4 5 6 7 cells are there which are having these bluish color filaments, that means there is a 7% reticulocyte count. So how you are calculate the reticulocyte count? Out of the 100 RBC, how many RBCs are having these filaments? That will be the number of the reticulocyte. If there are 50 RBCs in this field, okay, and there are 5% 5 reticulocytes are there, that means in 100 RBCs how many reticulocytes will be there? 10%. So that's how you can calculate the reticulocyte count. Just focus a area where you can appreciate the 100 RBCs, and out of 100 RBCs how many reticulocytes are there, that you can easily count or calculate. Okay, so remember, so when these RBCs, when you will see it on the spatial stain, that is the new methylene blue, you will appreciate some bluish thread or some bluish dot in these RBCs. Those are called as the, like this you will called as a, these are what? These are the ribosomal RNA. These are what? These are the ribosomal RNA, and that's why they are called as reticulocytes, and that's why they are blue in color, because normal RBCs, the mature RBCs, doesn't contain any RNA, so that's why they are appearing red in color, while the reticulocytes which are appearing blue in color because of the RNA which is there in these cells. So remember, reticulocytes, if you want to differentiate reticulocytes from the RBC, then how you are going to differentiate? What are the differentiating point between the reticulocytes and the mature RBC? Like here, the most immature cells that are there in the bone marrow, they are called as normoblast. Okay, Normoblasts get differentiated into reticulocytes in the marrow, and reticulocytes finally become the mature RBC. So what's the differentiating point? First of all, RNA. RNA will be there in the reticulocytes. RNA will be there in the reticulocytes, but not in the RBC. While the nucleus will be absent in both of the cells. Reticulocytes also not having any nucleus, RBC is also not having any nucleus. Which cells or which erythroid cells are containing the nucleus? That are the blast cells, normoblasts, that is also called as erythroblast. So erythroblast or the normoblast are the cells which are there in the marrow which contain the nucleus. Otherwise reticulocytes and RBCs both are the anucleate cells. So please remember, reticulocytes are not the nucleated cells. Reticulocytes are also the anucleate cells. Then what is the differentiating point between the reticulocyte and mature RBC? Reticulocytes will be having the RNA that is there in the reticulocyte, that is not there in the RBC. And remember, reticulocytes are larger cells as compared to the mature RBCs. So remember, reticulocytes are anucleate, larger RBCs. What are in reticulocytes? They are the immature form of the RBCs. And how they are differentiated from RBCs? Because they are anucleated and they are larger as compared to RBCs. And how you will make out whether they are reticulocytes or not? By looking the polychromatophilic cells in the peripheral blood smear. So if you can see the polychromatophilic cells in the peripheral blood smear, then you always have the stain that is called as supravital, and then you will able to make out the exact count of the reticulocyte. Even nowadays, the CBC analyzers can also calculate the reticulocyte. CBC analyzer can also measure reticulocytes. So we are having two important ways to calculate the reticulocytes. One is the smear itself, and second is by the machine itself. Okay. What is the importance of these reticulocytes? Why we are talking a lot about the reticulocytes? Remember, reticulocytes are mirror of the bone marrow erythroid activity. Reticulocytes are mirror of bone marrow erythroid activity. Okay, so if bone marrow is active, if bone marrow is having erythroid activation or erythroid proliferation, bone marrow erythroid proliferation is there, that time the reticulocyte count will increase in peripheral blood. If there is bone marrow erythroid proliferation, then reticulocytosis will be seen. Reticulocytosis will be seen. Reticulocyte count will be increased, but where? In peripheral blood. So whenever you want to see that whether our bone marrow is having active proliferation of erythroid or not, so it's not necessary to do bone marrow aspiration every time. Even by looking one parameter in peripheral blood, you can ascertain whether the bone marrow is having active proliferation or not active proliferation. So if bone marrow is having active erythroid proliferation, then in peripheral blood you will see the reticulocyte count will increase. Or if bone marrow is suppressed or bone marrow is having suppression of erythroid activity, then in peripheral blood you will see that reticulocyte count is also low. So if bone marrow is having suppression, bone marrow erythroid suppression is there, then there will be a reticulocytopenia. Then there will be a reticulocytopenia. Penia means reduction in the count. So in which conditions, in which anemias you will see that reticulocytosis is there, like in hemolytic anemias. This is very, very simple, but very, very important. Remember, in all type of hemolytic anemia, you will see that the reticulocyte count will increase. So whenever in the peripheral blood RBC destruction is taking place in form of hemolysis, that time bone marrow will help that anemia by throwing new RBCs into the peripheral blood. So whenever bone marrow become quite active, quite angry, that time it is going to throw the mature RBCs, and with the same time it is going to throw some immature reticulocytes into the peripheral blood. So whenever there is a hemolysis ongoing in the peripheral blood, that time the marrow become angry and it will throw newer RBC to compensate for its peripheral blood anemia, and that is called as hemolytic anemia. So please remember one very important concept, that whenever there is ongoing hemolytic anemia or ongoing peripheral blood destruction of RBC, that time the bone marrow become quite active and it will throw mature and immature RBCs into the peripheral blood, and that time you are going to see the reticulocytosis. Okay, and in the rest of the anemias, like in IDA, in megaloblastic, you will see that bone marrow remain quite suppressed even if there is a anemia. So that's why I told you that how you are going to see the response in iron deficiency anemia by assessing the reticulocyte count. Because in IDA condition, in iron deficiency anemias, the bone marrow is not helping at all. So bone marrow remains suppressed whenever there is a iron deficiency anemia. And as you start the treatment, you are giving the supplementation in form of iron. That time bone marrow again become active and it start throwing newer RBCs into the peripheral blood in form of newer RBCs and reticulocytes. Hence, within 1 week, you will see the reticulocyte count will reaches to its peak values. Okay, so that's how the reticulocyte count will increase in iron deficiency anemia only in treatment condition. In normal IDA, there will be a suppressed reticulocyte count. So that's why it is very, very important to ascertain the values of the reticulocyte count. So please remember, this is a very, very important concept, that where the reticulocyte count will increase and where the reticulocyte count will decrease. So please remember, there is only one condition I'm giving you for the increased reticulocyte count, that is the hemolysis. Otherwise, in rest of the all the anemia, you can see that the reticulocyte count remains low. Next is iron deficiency anemia. Sorry, not iron deficiency. We have already talked about the to differentiate it from the anemia of chronic disease. That is the next thing, anemia of chronic disease. Anemia of chronic disease, what does it mean? Anemia of chronic disease is the anemia that is seen in association with any chronic inflammatory condition, with any chronic inflammatory condition. Like the patient can have tuberculosis, that is also chronic infective condition, bronchiectasis, rheumatoid arthritis, even in some cancers also, like cancers. Cancer is also an inflammatory condition. Remember, in the cancer also, we are having a lot of the chronic inflammatory situation. So that's why cancers are also the one of the cause of inflammatory conditions. CRF, that is chronic renal failure. So not only these options, you can choose any chronic inflammatory condition where you will see the anemia. So whenever any chronic inflammatory disease is there, cancers are there, renal failure is there, chronic renal failure is there, and in those patients, if you see the anemia is also there, that means what kind of anemia it is? It is a anemia called as anemia of chronic disease. Okay. So what will be the morphology? In these cases, you will see normocytic, normochromic category. The RBC will be having normocytic, normochromic appearance, or they will have the microcytic, hypochromic appearance. Okay, please remember that in anemia of chronic diseases, which type of RBC morphology can be seen? The RBC morphology can be normocytic, or RBC morphology can be microcytic also. Next thing, how anemia can be there in inflammation. Why there is a anemia in inflammation? So what is the pathogenesis? Like we'll see, like whenever there is a chronic inflammation, Whenever there is a chronic inflammation, as you all know that chronic inflammation is associated with increase in interleukins like IL-1 will be increased, IL-6 will be increased, TNF will be increased. These are all the important chemical messengers which will be increased whenever there is a inflammation. Is it lagging? Is it audible and clearly visible to all of you, or is it lagging? Okay, okay, little bit lagging. I think now it's all right. So, if in any kind of chronic inflammation, what we are going to see in any kind of chronic inflammation, we are going to see important chemical messengers that are called as interleukins, which will be raised in any chronic inflammatory conditions. Okay, so like IL-1, IL-6, and TNF will be increased in these cases. So, whenever these interleukins are increased in any chronic inflammatory state, that time there will be certain proteins which will be increased in our blood. Those are called as acute phase reactant proteins. Acute phase reactant proteins that will also be increases in our blood, like CRP. You must have heard about CRP. Always, whenever any patient is having any kind of infection, we used to offer the CRP to that patient. Why we are going to offer the CRP to the pet patient? Because we are knowing that the CRP is also one of the acute phase reactant protein. Like fibrinogen, we also want to offer to the patient. What are they? They are the acute phase reactant protein. And with that, one very important protein which is there, that is called as hepcidin. So this is our molecule of interest, hepcidin. So remember, hepcidin is also one of the very important acute phase reactant protein which increases whenever there is any kind of chronic inflammation. Okay. So what is hepcidin? Why it is important? Remember, hepcidin at one time here it is acting like a acute phase reactant protein, and but hepcidin is also having one very important role, and that is called as it is also iron regulatory protein. It is also iron regulatory protein. Means in our body, whether the iron is increased whenever we are eating sufficient amount of iron, or iron absorption is reduced, that will depend on the hepcidin levels. If hepcidin levels are more in our blood, we are going to have less absorption of the iron from the GIT. And if we are having less amount of iron in our blood, then what will happen? Then the iron absorption will be increased because hepcidin levels will be low. So whenever hepcidin levels remains high, the iron absorption will be reduced, and wherever hepcidin levels are low, then iron absorption will be increased. So that's how hepcidin used to regulate the iron absorption. So hepcidin will be having two important things. First is hepcidin is a iron regulatory protein. Second, it is also a acute phase reactant protein. Okay, so here in the chronic inflammatory states, hepcidin levels are increased just because it's a acute phase reactant protein. But by virtue of its normal nature, it is also an iron regulatory protein. So whenever hepcidin levels are increased in these states of inflammation, it's going to block is going to block iron absorption from duodenum. So it is going to block the iron absorption from the duodenum, and as iron absorption is reduced, slowly serum iron will fall. So this is important thing. Remember, in anemia of chronic diseases, what happens to serum iron levels? Serum iron levels will be reduced. Why serum iron levels are reduced in anemia of chronic disease? Because in anemia of chronic disease, hepcidin levels will be increased as it is a acute phase reactant protein. But by its normal virtue, it is also a iron regulatory protein. So whenever its levels are increased, it is going to inhibit the absorption of iron from the duodenum. So that's how slowly serum iron will be falling in cases of anemia of chronic disease. But it is important to see that how it blocks the iron absorption. I'll tell you. Like this is the duodenum. Okay, duodenum will be lined by the duodenal cells. Like this is the one of the duodenal cells. I magnified it, and on the surface of this duodenal cells, we are having receptor like this for iron absorption. So, if iron will come from the food or the diet in ferrous form, and it will get absorbed into this cell that is called as duodenal cells by a help of receptor that is called as this receptor is called as DMT1 receptor. What is DMT1? That is called as divalent metal transporter, because it can only and only binds with divalent molecules. So that's why the iron will always be in ferrous form to be absorbed by these duodenal cells. So remember, whenever iron is in the ferrous form, then only it is going to be absorbed by the duodenal cells. If iron is in the ferric form, this divalent metal transporter is not going to have any action here. So whenever in our food we are having the ferric form, that ferric form will get converted into ferrous form, especially by the acid which is there in our stomach, like hydrochloric acid. So hydrochloric acid is very very important for iron absorption. Why? Because it will keep the ferric into the ferrous form. And in any disease, if the hydrochloric acid is reduced in our stomach, we are going to have the malabsorption of iron also. Okay. So that's why whenever the physician used to give us the iron supplement, they also gives us the vitamin C with the iron supplement. Why the vitamin C is given? Because vitamin C is ascorbic acid, and acid is going to help the iron absorption by keeping it in the ferrous form. So you got the point why ascorbic acid is always given with the iron supplement to increase the iron absorption. So remember, whenever there is a increased acid in the stomach, acidity is increased, that time the iron absorption will be increased. Whenever you are going to increase the alkalinity of the stomach, that time you are going to decrease the iron absorption. So that's why whenever you want to take the iron, you have to take the iron on the empty stomach, because the acidity will be increased. And whenever you are taking it with the food or with the milk, it is going to reduce the iron absorption. Why? Because milk is a alkali. Milk is a alkaline in nature. So never take iron tablets with the milk. Always take the iron tablets with the ascorbic acid or vitamin C to increase its absorption. Okay. So who is going to keep this ferrous form? This is the hydrochloric acid of stomach is helpful here. So that's why remember, ascorbic acid or vitamin C increases iron absorption. Okay. So here, when this ferrous form of iron is going inside the duodenal cells, that will be done by the divalent metal transporter. But we are not finished here. Why? Because this iron has to be reached up to the blood itself. So this is the blood vessel, the nearby blood vessel, and we want that this iron should reach to the blood, and from the blood it will reaching to the bone marrow, and in the bone marrow we are going to utilize that iron to make the hemoglobin molecule. So now this ferrous form or this iron will be entering into the blood vessel from the duodenal cells by action or help of one receptor that is called as ferroportin. So ferroportin is present on the duodenal cells, on which surface, that is called as basolateral surface. Basolateral surface of duodenal cells used to carry one very important transporter of iron molecule that is called as the ferroportin, while DMT1 receptor is present on the luminal surface of duodenal cells. Luminal surface of duodenal cells. Okay, so this is important. If question is there that which is the most important receptor for iron absorption, then you will say DMT1. If they are asking you which is the most important receptor present on the duodenal cells for iron absorption, then your answer should be DMT1. Okay, but if they will ask you the site of the receptor, like if they are giving you specific site, like they are asking you that which is a special receptor present on the basolateral surface of the duodenal cells for iron absorption, then you will say the answer is ferroportin. Okay, that is present on the which surface? The basolateral surface. Why we are talking about these two important receptors? Because hepcidin has to act on one of these receptors. So on which receptor hepcidin will act and it will block the iron absorption? That is the question. So remember, hepcidin will block iron absorption by inhibiting ferroportin. So please remember, this is not the DMT1 which is blocked by the hepcidin. It is actually ferroportin which is blocked by the hepcidin. So that is the very important question, that hepcidin blocks iron absorption from the GIT in anemia of chronic disease by blocking which receptor? Option A DMT1, option B ferroportin, option C both of the above, option D none of the above. The answer will be the ferroportin. Okay, you got my point? So remember, please remember, ferroportin is the most important receptor here. Okay, now when this iron is bind with transferrin in the blood. Okay, so now this iron will reaches to the blood with the help of the ferroportin, and in the blood it will bind with the transferrin molecule, and with the help of the transferrin molecule it will get transported to the bone marrow. In the bone marrow, what will happen? In the bone marrow you will see that there is a cell in the center. Okay, and there are so many cells which are surrounding this large cell like this. This centrally placed large cell will be surrounded by so many other cells that will be having the nucleus also, like this. Okay, and iron will reaches first of all to this. So whenever from blood iron will be reaching up to the bone marrow macrophages. So what are these cells? The centrally placed cells are bone marrow macrophages. And what are these cells? These are cells are called as erythroid cells, which are there in the marrow, erythroid precursors. So these are the erythroid precursors which are surrounding the centrally placed macrophage, and they are waiting for the iron to be given to these cells by the macrophage itself. So whenever from the blood iron is reaching to the bone marrow, which is the cell to receive the iron marrow, that is the bone marrow macrophages itself. Then bone marrow macrophages will serve this iron to the rest of the erythroid cells so that they can make the hemoglobin molecule out of this iron. Okay, but this these macrophages are going to give this iron to the erythroid cells by help of one receptor that is present on the bone marrow macrophages, and that is called as, this receptor is again called as ferroportin. So remember, there are the two sites where you can see the ferroportin. Ferroportin is present on the duodenal cells basolateral surface, and ferroportin is also present on the bone marrow macrophages. With the help of bone marrow macrophages, ferroportin is going to give the iron to the rest of the all the important hungry erythroid cells so they can make the hemoglobin out of this. But whenever there is an increased hepcidin, so hepcidin will block this thing also. So hepcidin will block ferroportin in macrophages also. Then what will happen in bone marrow? This is the most important step here. Remember, whenever bone marrow iron is entrapped within the macrophages, then this iron is not reaching to the erythroid cell. Then erythroid cells are not able to make the sufficient amount of the hemoglobin molecule, and that's why patient is having the anemia. You got the point? Why inflammation can leads to anemia? The important thing is, whenever there is an inflammation, that time the patient is having increased amount of interleukins in their blood. Okay, and these interleukins are going to increase the acute phase reactant proteins within the blood, and these acute phase reactant proteins like hepcidin are also iron regulator. So whenever hepcidin increases in these inflammatory condition, hepcidin is going to block the ferroportin at the duodenal surface, so that there will be a low iron slowly, and as it will block the ferroportin at the surface of macrophages also, so the bone marrow will have the iron, but this iron remains entrapped within the macrophages of the bone marrow, and all the erythroid cells which are there, they will remain hungry for this iron, and that's why patient will have the anemia. So bone marrow iron will remain entrapped. This is very important word, entrapped within macrophages. So this is the line which was asked in your exams, I think 2 to 3 times, like 2016 they asked, 2018 they asked, 2020 they asked. 3 times they have already asked this question, that in which type of anemia the iron will remain entered within the bone marrow macrophages, and the remaining erythroid cells will remain hungry for this iron, and there will be anemia. So there will be no iron to erythroid cells, so there will be no hemoglobin synthesis in the RBC, in the erythroid cells, and that's why patient will have the anemia. But the question will be this one. So there are three important questions which are related to anemia of chronic disease. First question, that which is the important molecule for pathogenesis of anemia of chronic disease? Answer will be hepcidin, which is the most important protein that is there in anemia of chronic disease, that is going to leads to anemia. So this is the most important molecule, that is hepcidin. So this is the first question. Second question, hepcidin blocks iron absorption in anemia of chronic disease by acting on which receptor? That is ferroportin. That will be the second question. Okay. Third question, which receptors are blocked on the surface of the bone marrow macrophages in anemia of chronic disease? That is the third question. That is again the ferroportin. Okay. Fourth question, in which type of anemia the bone marrow iron remains entrapped within the bone marrow macrophages? The third question is again the anemia of chronic diseases. Okay. And now tell me, if bone marrow iron remain entered within the macrophages, and if you assess the serum ferritin in this patient, then what will happen to serum ferritin levels? Whether it comes low or high. What is serum ferritin tells us? The serum ferritin tells us that what is the status of bone marrow iron stores. If bone marrow is having iron within it, that means serum ferritin will remain high or normal. Once the bone marrow iron stores are depleted, that time what will happen? Serum ferritin is going to fall. Like in iron deficiency anemia, you must have seen that the serum iron is falling, serum bone marrow iron is also falling. That's why the serum ferritin is also falling. But here, what is happening? Serum iron is falling because iron is not being able to be absorbed from the GIT. But what is happening to serum ferritin? Bone marrow will always have the iron, but at the wrong side. What is the right side? The right side will be the erythroid cells itself. But here the wrong side is bone marrow macrophages. So anytime after 2 months or 3 months or 4 months of the inflammation, if you'll see that slowly serum iron will get reduced due to the inhibition of the absorption from the GIT, but the serum ferritin levels will remain high or normal. Why? Because always the ferritin molecule or iron molecule will remain entered within the macrophages of the bone marrow. It is even at the wrong side, but still ferritin will remain normal high. Why? Because ferritin cannot differentiate whether the iron is there within the erythroid cells of the marrow or whether it is there in the macrophages of the bone marrow. If this iron is there within the bone marrow erythroid cells, it remains high. Ferritin remains high in the blood. Even if it is there in the wrong side, that is the bone marrow macrophages, it cannot differentiate. It still remains the high. So this is why serum ferritin levels remains high in cases of anemia of chronic disease. So that is the differentiating point between the anemia of chronic disease and iron deficiency. If you remember, I told you that how to differentiate anemia of chronic disease from the IDA. The best parameter will be the serum transferrin receptor assay with the ratio of the log ferritin. Second important will be the serum receptor transferrin assay, and the third is important is ferritin. Why ferritin is important? Because ferritin will be low in iron deficiency anemia while it remains high in anemia of chronic disease. You got the point? Why it is increased? Because here the iron remain entrapped within the bone marrow macrophages. So that's why ferritin levels will always remain high in the blood always. So you got the point? So this is very, very important differentiating point. Don't depend on serum iron for differentiating anemia of chronic disease from iron deficiency, because in both of the conditions you can see that serum iron will remain low. In anemia of chronic disease also serum iron remains low because it is not getting absorbed due to the blockage by the hepcidin, and even in iron deficiency anemia also serum iron remains low. So remember, serum iron is not a good test to differentiate iron deficiency anemia from anemia of chronic disease. What is the good test? You will go for the serum ferritin, or if ferritin is given then it is good answer. If serum transferrin receptor assay is given, that is even better than the ferritin. And if options are suggesting you transferrin receptor ratio with the log ferritin, that is the most best answer. So now you got the answers. Last thing about the anemia of chronic disease, that what should be the treatment. The treatment will be simple. Treat the cause, treat the inflammation. Don't treat the anemia. First of all, you have to treat the cause or you have to treat the inflammation. Okay, so that is the answer. And in CRF cases, chronic renal failure cases, you have to give one drug from the outside, that is called as exogenous erythropoietin. We have to give. Why? Because due to kidney disease, there is one very important growth factor that is released from the kidney itself, that is the erythropoietin. As kidney is already diseased, so kidneys are not able to secrete the erythropoietin in these anemias that is related to CRF. In that time, you have to give the erythropoietin from the outside so that the growth factor for RBC should be there. So what is that exogenous erythropoietin called as? It is called as drabopoietin. The name of the drug is drabopoietin, that has to be given in CRF conditions. So please remember that in which type of anemia of chronic disease we are also giving erythropoietin from the outside, that is the CRF, because in CRF cases the kidney is already diseased, so there will be no erythropoietin secretion. So no erythropoietin from diseased kidney. So that's why we are giving the erythropoietin from the outside. Not in all the cases, you have to give it only in the CRF cases, not in other chronic inflammatory conditions, because in those conditions, erythropoietin will be secreted from the healthy or normal kidney. But whenever kidney is already diseased, already damaged, that time erythropoietin will not be able to be secreted. That time you have to give the erythropoietin from the outside source. So, so we have covered today the one of the very important anemias, the iron deficiency anemias, anemia of chronic diseases. In the next lecture, I'll tell you how to differentiate anemia of chronic disease and IDA from the